प्रतीक आता स्लाइड शो झालाय का?
येस येस मॅम.
फुल स्क्रीन झालाय ना?
हो
ओके,
हो फुल स्क्रीन.
आपण स्टार्ट करूयात आता. सर मी स्लाइड रन करेल, आपण स्टार्ट करूयात. इट्स ओके.
हा मला काय हरकत नाही.
ठीक आहे. आपण YouTube लाईव्ह स्टार्ट करतोय प्रतीक आणि
Yes,
रेकॉर्डिंग.
झालंय मॅम, चालू झालंय.
ओके. Namaskar. I am Dr. Jyoti Shinde, along with my doctor colleagues, Dr. Pushkaraj, Gayatri, Snehal, and Anjana. Very much delighted to welcome you all. Before starting today's lecture, I am taking it's my privilege to introduce you about MCF, that is Mukta Charitable Foundation. Mukta Charitable Foundation is NGO, non-profit public trust, established by socially conscious citizens. Some of the trustees like Captain Ashok Gole sir, Dr. Mahajan, Dr. Rupa, and Dr. Anuradha Tarkunde madam is also with us today. Mukta Charitable Foundation's flagship project is Mukta HIV Samvad Helpline. So we have started this in Pune with one counselor, and now today we have another branch in Patna, Bihar, and having more than 15 counselors. Our helpline is the India's largest HIV helpline. As the HIV epidemic has reduced, we have fanned out in different directions. So there are so many other projects that I am very much proud of. Some of them are like de-addiction medicine. We conduct addiction related lectures for general practitioners, counselors, social workers, and nurses also. We also create the awareness about ill effects of addiction in schools and college students, which is very rampant today. Another project of Mukta Charitable Foundation is Shala Beyond Books. This is for school children, where we teach life skills about sexuality, about gender, and also aware them about addiction. We also have Corona helpline in COVID pandemic. Another project is online learning webinars for the doctors to upgrade their knowledge. So in COVID pandemic, there is spread the science, not the virus was the webinar. Then urgency medicine course for rural doctors, skills that the wins. Diabetic is very common now. For diabetic to become a more master in diabetics, moving to the master was the webinar. And then other one is so now there are some ongoing courses also. So tell more about that courses, that is de-addiction course and pharmacological course. I request Dr. Snehal and Dr. Gayatri, can you please explain about that ongoing courses, pharmacology and de-addiction? Dr. Gayatri?
Sure. Good afternoon, everyone. I welcome you all on behalf of Mukta Charitable Foundation. The COVID pandemic has made us realize that we, the general practitioners and family physicians, are the backbone of our healthcare system. So it's our responsibility to have a thorough knowledge of modern medicine and upgrade our knowledge from time to time. Taking this into consideration, Mukta Charitable Foundation has joined hands with Bharati Medical College Pharmacology Department and launched a unique course, online course for doctors, Pharmacology and Beyond. It's a lecture series specially designed for general practitioners regarding pharmacology, its applications, along with the basics of clinical treatment. The lectures will be delivered by renowned experts in the field of medicine. To know more about this course, kindly check your chat box. We have given the details and the link to register in the chat box. Thank you. Now I hand over to Dr. Snehal for further information.
Thanks, Gayatri. So we are going to start one offline course, which is a certificate course in the addiction medicine, and it will be on 26th and 27th of February. It is happening in Pune, BJ Medical College. I will just post the details in the chat box here itself, and the link to register will be given. The fees for that is 525 rupees. Okay, so it is a 2 days course, and there are 14 sessions related to addiction medicine. Thank you so much.
Thank you, Dr. Snehal and Gayatri. We Mukta Charitable Foundation also works with Pratham Education Foundation for the project called First Aid for All. Actually, today's lecture is an extension of this project. In these projects, we doctors of MCF give answers to the doubts of youths who join from different parts of rural India. It is always exciting for us to clear their doubts on snake bites. And in our doctor community also, there are some myths like tourniquets, ice, and suction are useful in snake bite treatment. But the fact is that all these techniques has a lack effectiveness, and they may lead to the amputation or sometimes permanent disability also. So let us know more about the mysterious world of snakes. So from today's lecture, so I request Dr. Pushkaraj Vanshan to introduce our today's speaker. Dr. Pushkaraj is a very enthusiastic, social-minded and young doctor practicing in Konkan region of Maharashtra. He is practicing in Tadil village near Dapoli, and he is very good writer also. So I request Dr. Pushkaraj, please introduce today's speaker.
Thank you, Dr. Jyoti. Hello and good afternoon, doctors. I welcome all the doctors on behalf of Mukta Charitable Foundation. Myself, Dr. Pushkaraj, and I am here today to introduce our today's speaker, Dr. Suyog Bhagwat sir. Dr. Suyog Bhagwat has done his MBBS from Nair Hospital and MD Medicine from GS Medical College, Mumbai in 2015. He has published a paper in International Journal of Medical Science about hypertensive subjects with diabetes as comorbidity. He has special interest in cardiology and runs a 2D echocardiography center and a 4-bedded ICU with invasive ventilator. Also, due to his keen interest in nephrology, he is maintaining a dialysis unit 2 in Dapoli under one roof as Bhagwat Multi-Speciality Hospital. As you all know, snake bites can cause severe cardiac problems depending upon the toxins. So, today we are all honored by having Bhagwat sir as our today's speaker, as his deep interests are in cardiology. His expertise advice will definitely help us upgrading our knowledge about snake bite management in our OPD. Also, we will be able to distinguish the severity of the bite and will be able to shift our patient to higher centers and save their lives if necessary. So, ladies and gentlemen, without further delay, I request Dr. Bhagwat sir to take charge of the meeting and help us to improvise our knowledge about the myths, facts, and management of snake bite. Thank you. Dr. Bhagwat sir.
Thank you, Dr. Pushkaraj. Am I audible?
Yes.
Okay, so
Yes,
I am
sir.
Dr. Suyog Bhagwat, and I am very thankful to Dr. Pushkaraj for inviting me to deliver this lecture on snake bite. I have a keen interest in snake bite because I have done my post-graduation in KM Hospital, Mumbai, and there we just saw very few patients of snake bites, and that too at very critical stage. But here when I shifted to Dapoli, which is my hometown in Konkan region, so here I saw that there are rampant amount of bites which are patients with bites are presenting here. So many patients with snake bites, scorpion sting, or many unknown bites are coming here, and I had to prepare myself to to treat these patients. So I have gained a lot of knowledge with various exposure that I have with here in this Dapoli region. So let's start with snake bite, its management, and let's just clear some doubts or what we say are myths about the snake bite. So we start with the presentation of snake bite. Next slide, please. So basically, why are we talking about snake bites? We're talking about snake bite because it is an acute emergency. It is an emergency where if we as a doctor, if we intervene, then we can actually change the prognosis of the disease. And we as a professional or as a doctor, if we do not intervene, then it is sometimes lethal. There are many, usually it happens with the various people in rural areas, and they have got a lot of misconceptions about the snake bite. So here we are today to clear those misconceptions and also to guide various general practitioner and other experts about what is the right approach to treat the snake bite. So basically it is a preventable health hazard. That's why we have to talk about it. And there are so many bites in the rural areas, especially in India and especially in Konkan area. There are so many bites and so many patients presenting with bites. Next. So these are first few slides we will just rush through because it is more of a theoretical knowledge. So here we can see there are mainly many species of snakes, out of which very few are poisonous, and amongst very few poisonous snakes there are few which are important to us because of its frequency of bite. So here second point flashes that there are two types of snake bites, that is from Russell viper to hump nose viper, cobra and crate. And third point flashes that it's the commonest site where we see are in paddy fields, which are more common in Konkan region, followed by home or road. Next slide, please. So next slide. So this is basically about the commonest location on the body. Commonest location on the body is below the knee, on the foot, or sometimes the patient is sleeping, it is on the hand. But this is a fun slide just to put that nowadays we come across a lot of people who are like they are Sarpamitra, and they help in tackling if there is any snake. But there are few Sarpamitra who are very over enthusiastic, I would say, and they do present to us with a lot of complications. So this is a fun slide. So basically there are two categories of snakes. Three categories, out of which two are important. One is Elapidae family and second is Viper. These are the sea snakes, very uncommon. Though we stay near seashore, we see very patients of sea snake bites. So we will be concentrating more on neurotoxic snake bites and vascular toxic snake bites. So neurotoxic, that is Elapidae. We have Indian cobra, king cobra and crates, out of which Indian cobra and crate, that is nag, and crate means manyar. These two are very common. Next slide. In the vascular toxic, there are mainly two subgroups, typical vipers and pit vipers. Pit vipers are uncommon. Typical vipers we have two. Next slide. So this is regarding a little bit of knowing which type of snake is it, whether it is a neurotoxic or a vascular toxic, or whether it is a myotoxic snake. So venomous sea snakes have flattened paddle-like tails and tiny flanks. So when we look at the tail of a snake, if it is a flat tail, it is usually sea snake, very rarely seen. So we won't give a lot of time to this. Next slide. This is if sometimes what happens when the patient comes with a snake bite, they usually come with a snake. They do kill the snake with the belief that if they kill the snake, then there will be less poison, which is absolutely wrong. But most of the time, patient and the relatives will come with a snake. So if we can identify the snake, it helps us in diagnosing. If we cannot identify the snake, still it is not a problem. But if we can identify, then these are few slides just to know if we can identify the snakes. So how do you know whether it is venomous or non-venomous? If it is non-venomous, then you see, open the mouth and you see that there are no two flanks. The flanks are not there. These are small teeth, the hollow teeth, and you do not see any glands. But mainly the flanks which are there are in the poisonous snakes, are not present in the non-venomous snakes. Next. And this is again what I told you about the tail. If it is a flat tail, it is a sea snake. If it is round or cylindrical tail, it can be poisonous or non-poisonous. So depending on the scales, so these are the snakes do have scales. The scales can be incomplete or complete, or the scales can be large or small. So if they are complete scales, you see a whole of a hexagon, then they are usually poisonous. If they are incomplete scales, which we will see in the consecutive pictures, then they are non-poisonous. These are few points just to identify, if we can, the poisonous snake or unpoisonous snake. So we see the tail. If it is flat, if it is a sea snake, which can be poisonous. If it is cylindrical, it can be non-poisonous or poisonous. And then we see the scales. Scales, if they are large and complete, it can be poisonous. But if they are incomplete and small, it is usually not poisonous. If you have this knowledge, it is okay. If you do not have this knowledge, it is okay. So why it is okay if you do not have the knowledge, we will be talking in the later slides. Next. So this is what we usually see in the pharmacology, the forensic medicine book. The third supralabial touches the eye, which is a iconic for cobra. And diagnosing or identifying a neurotoxic snake, which is cobra, which is nag, which is very common, is important because if we are not able to know what is if it is a neurotoxic trait, because crate is very easy to identify, but cobra may not be that easy. Usually the relatives only tell you what kind of snake it is, but you should know. If you can diagnose if it is cobra, then it becomes easy for you, because these neurotoxic, they do not have any laboratory investigations which can help us identify the whether it is a poisonous or venomous snake bite or non-venomous snake bite. In a vascular or vascular toxic snake bites, it is possible, because we can do the clotting time test and know if it is if there is any systemic envenomation. But in neurotoxic, we have to completely rely on our clinical judgment. We have to completely rely on the proper history taking and eliciting various signs, which we'll be talking in the later slides. So if we can identify if the patient, if the snake is neurotoxic, then it is a little helpful in the management. Next. So these are the pictures, Russell viper and saw-scaled viper. So Russell viper is also called as Gonus, and saw-scaled is also called as Fursa in local language. These are the two who are the culprits, and most rampant they come is the vascular toxic. So I have been working in Dapoli for last 6 years, and I have seen 99.99% of them are these two. These are the two which are culprits, Russell viper and saw-scaled viper. These are very typical. If you see them, you know they are vascular toxic. So these are the two which are culprit. Neurotoxics are very rare, but they can be very life-threatening also. This is great. This is also called as Mania. So it is a black, slim, and long or short. So if you know if it is a crate and it is neurotoxic, it is something which causes an occult bite. We will be talking about it in later slides. So Mania is little something which we should be worried about, because they have a different presentation. Next. So this is again little theory. Why do they cause? What are the venomous things which are present in the glands and which are spread through the flanks into the body or the circulation? So these are basically procoagulant enzymes. And what do? They usually cause lot of clotting. Contradictory to the fact that what we see is bleeding as a manifestation, but what happens is they are which causes a lot of clotting in the vessels or the capillaries, and then it causes consumption coagulopathy. So this uncontrolled clotting uses a lot of your clotting factors and platelets, and the platelet and clotting factors which are necessary for the maintaining normal blood flow. And if because of this consumption coagulopathy or disseminated intravascular coagulation, we also call it as a DIC. So there is a bleeding which is a manifestation. So they do not cause bleeding, but they cause coagulation, and that usually manifests into bleeding because of consumption coagulopathy. So this is basically pathology. Next. So these are various proteins, hemorrhagins, hyaluronidase. These are the two which causes vascular which causes bleeding in vascular toxic snake bites, and pre-synaptic neurotoxins and post-synaptic neurotoxins. They usually causes neurotoxicity, out of which post-synaptic neurotoxins are more common, and they have a pathophysiology which is similar to the myasthenia gravis. So they usually attach to the acetylcholine receptor and they block it, and that's why they cause muscle paralysis. So this is again theory. We will be talking more about practical. Next. So this is important. This slide is important. After this brief introduction of various types of snakes, which are usually vascular toxic snakes and neurotoxic snakes. Out of the vascular toxics, there are two which are important. One is saw-scaled and Russell viper, and neurotoxics, there are two which are important. One is cobra and crate. The identification of the snakes, if you know, it is good. If you don't know, it is not a problem. But what you should know that if there is a snake bite, then what are the first aid treatment that you should be doing? This can be done by the primary physician, primary practitioner, general practitioner who first sees the patient, or the non-medical person who is around. So this is very important to know what is the first aid treatment, what are the myths about the first aid treatment. Then we will talking about rapid assessment and resuscitation. Then we talk about clinical, detailed clinical assessment and species diagnosis. What are the investigations that we will have to do? How do we do antivenom treatment? Then how do we see the response of the antivenom treatment? Then what is the treatment of the bitten part or the local inflammatory signs? And then we talk about the little bit about the life-threatening complication and its treatment. Next. So this is important, first aid treatment, because I've been told that this lecture will be seen by a lot of non-medical people also. So this is important slide. Performed by bystander or by snake bite victim only. So what is important if you are there with a person who has been bitten by the snake? First important thing is reassurance. You have to tell them at any cost, if you're a doctor or non-medical, that there are view that is 1 out of 100 bites would cause problems. So 99% of time you are safe. This anxiety causes a lot of problem. If patient is not anxious, then it helps us diagnosing or treating him well. So reassurance is very important, which we should not underestimate. Reassurance is very important. Then second is avoid any interference with the bite wound. So what do we have to do is immobilize the limb with a splint and roll it with a crepe bandage if available, or any cloth what is available at that site. But what we should not do is important than what we should do. We should not interfere with the bite wound, as it may lead to increased infection, increased absorption of the venom, and increased bleeding. Next slide. So pressure, what is pressure immobilization method? Pressure immobilization method is basically you will have to put a splint. If it is arm, then at the whole arm, and if it is leg, on the whole leg, you will have to put a splint and roll the full limb, irrespective of the fact where the bite is. You will have to immobilize the full limb, upper limb or lower limb, with a sling in between and a roller bandage or cloth or any crepe bandage if available. You will have to immobilize the limb, and you will have to put a elastic crepe bandage around the whole limb. It should not be very tight. We should be easily able to slip our fingers through the bandage. It is important. So because if it is very tight, we have this misconception that if we put this limb, put this crepe bandage, then the poison won't go in the circulation. So we are just trying to stop the lymphatic circulation, which is in the superficial area, but deep arterial and venous, we cannot avoid it. And we should not be the bandage should not be very tight, because it may cause ischemia and it may cause problems. Third important thing is it should be ideally put by a medical professional. If not, then non-medical. Third, so this is basically a diagram. Next, this is basically a diagram which shows that even if the bite mark is at an ankle, you should start your splint from the tip of the toe. Similarly, upper limb, the whole of the limb should be splinted and not above it. What people do is they put a tight tourniquet above it, considering the fact that poison will not go. So that is not a thing. Why are you doing this? Just to immobilize, to avoid any movements of the limb. So this is a good pictorial diagram which is showing us how we should go ahead with the first aid. Next. So this is not very important. This next. So this is a thing which we need to tell to the non-medical people. Useless and dangerous methods, what we are doing nowadays, or which is believed to be right in rural area, irrespective of lot of irrespective of fact that we tell them not to do it. So basically making local incision and pricks at the site of bite causes bleeding, it causes increased absorption. So you should not interfere with the bite at any cost. The doctor should do it, not any non-medical person. Attempt to suck the venom, a useless method. The time the snake bites you, it goes into the circulation through the capillaries, so you can't just remove it to your mouth, which is a wrong thing which is shown in the movies, which is absolutely wrong. Use of snake stones, this is something I don't know, but then people do maybe using these snake stones, they do give electrical shock, which is wrong. Topical installation of the various chemicals and herbs, nothing works, absolutely nothing works. Only one Sanjeevani is there, which is anti-snake venom, so nothing else works. So do not apply any chemical or herb, it just increases the local infection. And this last important bit, which even if we tell, they don't listen, the people don't listen, is do not attempt to capture, handle or kill the snake. It has got nothing to do with it. Has the snake has already bitten you, because it was a response. He was trying to protect himself, and he bit and he went. So now you just trying to find him and capture and kill him. It is not going to help anyways. Next. So next is rapid clinical assessment. Next. So whenever a patient of any acute emergency comes to you, irrespective of the fact whether the patient is serious or no, these are the important things that you should be looking at. First is oxygen administration if required. That is not must. What is important, you should put us IV cannula, because what if patient is going to be in trouble, what you have to give is anti-snake venom, which only thing we can do. So there should be good IV access. But that is the first thing you should do once a patient reaches the clinic. Second is ABC, that is airway, breathing and circulation. If patient, which usually happens, neurotoxic snake bite, patient don't come early, and they will come after a few hours, and that time you see that patient is having problem in difficulty in breathing. So you must assess the airway, you must assess the breathing, and there are few clinical tools to assess the breathing without any lab investigations. So only signs that we have to elicit, so we will be talking about it. And then definitely you have to see the circulation, that is you have to see the pulse, what is the rate, you have to see the blood pressure if patient is having hypotension or no, or hypertension or no. You must assess the level of consciousness, because neurotoxic snake bites or vascular toxic snake bites can cause altered sensorium in the later stage. Vascular toxic snake bite can cause bleeding inside the brain and cause altered sensorium. So sensorium is important, and definitely you should not come across this thing, but if patient is in terminal conditions, CPR. So this is just emergency. Next, detailed clinical assessment. Next. Detailed clinical assessment, as we all know, we are doctors. First thing we should be talking about is the history of how it happened, when it happened, where is the bite, if he has seen the snake, if he has not seen the snakes. History is very, very important. How the symptoms started, how they progressed, what are the current symptoms. So this gives you an idea what patient is in problem. Third is site and bite and time. It is important because time between the bite and the symptoms, they are specific for vascular, toxic and neurotoxic. So you should know the time of bite. Usually patient do present after 12 hours also. Some patient will present within an hour. So you should know if patient is presenting late, there are more chances that patient may land up in trouble. Snake identification, we talked about it. Next, clinical presentation, important. Next. So clinical presentation of snake bite victim depends upon the species of the snake, amount of venom injected, season, and whether patient is snake is fed, unfed. That is not important for us. Next. So this is basically a graphical representation of how you should approach a snake bite. So if you are suspecting a snake bite, if the patient or the relative have seen the snake, so it is a snake bite. So there can be two types of bite: occult snake bite or overt snake bite. What are occult snake bite? You don't see any flank marks. So that's what I was talking about, the crate. You don't see any flank marks, but patient has been bitten in the night. Patient doesn't know if he has been bitten. What happens is in the early morning, he comes with severe abdominal pain, and there will be neuroparalysis which will follow him. He doesn't know if there is no bite. We cannot see if there is any flank marks, but what happens, he just presents with the abdominal pain, and he has got a neuroparalytic symptoms, which usually happens in the morning because patient is sleeping. So this is what we call as a occult snake bite. So and one more important thing about this is there are no local signs. So you don't know if there is flank mark, you don't know if there is swelling, but patient just presented with abdominal pain and neuroparalytic signs. So this is something we as a clinician should know, that crate can cause this kind of cunning presentation. This is called as occult snake bite, and we should be very well aware of this very fact of crate bite. Abdominal pain and neuroparalysis without any local signs can be a crate bite presentation. Then what second type of bites are overt bite, which can be 70% non-poisonous and 30% poisonous. If they are poisonous, non-poisonous snake bite, they won't cause any symptoms. There will be maybe little inflammation at the local site, so don't worry. In the poisonous also there are two, dry bites and symptomatic. In dry bites, you just see a flank marks, there is no local inflammation, there is no poison which has entered your body, and you don't have any systemic symptoms. So these are the dry bites. And then what comes is a symptomatic bites. Symptomatic bites are predominantly two types, which we should be more talking about, and not the muscle related myotoxins. So two important thing is, one is vascular and second is neurological, neuroparalytic. So vascular toxics are mainly vipers and mainly Russell viper and saw scale viper. So vipers, V for V, these are vascular toxics. We have seen those two culprits in the picture. How would they present? They will present with a flank mark. They'll present with a good amount of local inflammation. There will be swelling, maybe sometimes necrosis. So this is how they'll present, and they'll present with bleeding. Bleeding will start in the gum. Bleeding may start as a hematuria. Bleeding may go in the internal organs. It may cause intra-abdominal bleeding, intracerebral bleeding. Hemoptysis, I have seen a lot of hemoptysis patient. I have seen a lot of hematemesis patient. So they can cause bleeding if the presentation is late, the patient has come late, or the amount of venom was more. So depending on this fact. And second presentation is neuroparalytic. So this is very important. We as a doctor should know, if a patient comes with a snake bite, he has got a little bit of local inflammation, he has got a flank mark, he doesn't know whether it was a snake or someone else, he doesn't know if it was a snake, which snake it was, then it is for us to decide whether it is neuroparalytic, which is not there in lot of physicians, lot of clinicians. They don't know how to diagnose a neuroparalytic snake bite. So that is what we should be more focused about. Because a patient of vascular toxic snake bite comes to you, you do a BTCT and you see that clotting time is high, more than 10 minutes, and you know it is a vascular toxic snake bite, you start the treatment. But neuroparalytic, you don't know. So how do we know whether it is neuroparalytic? There are a few signs that we should be talking about. First is the ptosis, that is eyelid are drooping down. This may not happen early, but then you will have to elicit if there is ptosis. We will be talking about it in detail after some time. Second is diplopia, that is double vision. Third is dysarthria. The patient has got difficulty in speaking. There is slurring of speech. After a bite, if there is slurring of speech, think about neuroparalytic. Dysphonia, nasal tongue, nasal regurgitation. Patient, if he is asked, there will be nasal voice because there is paralysis of the bulbar muscle. If there will be nasal regurgitation, you ask the patient to take a sip of water, the sip of water will come through your nose. So this is nasal regurgitation. So ptosis, diplopia, double vision, dysarthria, dysphonia, then nasal twang, nasal regurgitation, and at the end dyspnea and dysphagia. If a dyspnea sets in, then there's a respiratory muscle involvement, and usually these are very serious case patients and they will require artificial ventilation. Next, now we have seen a symptomatic patient would come to you with a snake bite and he'll be having palpitations, sweating, tachycardia, tachypnea, hypertension, nothing to worry about. Pale extremities, nothing to worry about. What are we supposed to worry about? We will talk about it. Then there is something called as dry bite. Dry bite is just flank marks, no local inflammation. If there is local inflammation, it is less than half of the limb. So if you have got a bite at your toe, then the swelling will be less than below your knee. So that is the dry bites. Or these are basically called as moderate categories, but dry bites will cause local inflammation and flying marks, no systemic symptoms or no high-end local symptoms also. Next, occult snake bite, we talked about it. A crate bite victim, I'll repeat it, crate bite victims often present in early morning without any local signs. Patient was healthy at night. In the morning, he gets up with the epigastric, severe epigastric or umbilical pain with a vomiting, persistent for 3 to 4 hours, followed by typical neuroparalytic symptoms within few hours. So these are the presentation. You should be worried because you don't know why it has caused it. So this can be crate bite. Neuroparalytic illapid envenomation. This is what we were talking about. Now what we should be focused on the first point, which is typical symptoms within 30 minutes to 6 hours for cobra bite and 6 to 24 hours for crate, and it can be as late as 36 hours. So if you got a bite, symptoms may start within half an hour up to 6 hours, and after 6 or up to 24 hours in crate bite. And what are the chronology of the appearances? First is heavy eyelid. If patient has got heavy eyelid, there may be complete or incomplete ptosis. If patient do not have ptosis and has a history of a snake bite, you should elicit. And if the BTCT is normal, which means you have ruled out if there is vascular toxic snake bite, then to confirm whether it is neuroparalytic snake bite, what you have to do is ask the patient to look up. So this is how you should ask the patient to look at your fingers, a horizontal finger, take it above, keep the neck steady, ask him to see. There'll be frowning at your forehead, and if patient can maintain this site and there is no spontaneous drooping, then this is the way you should be able to elicit the ptosis. Second is diplopia. So patient will ask patient if he has a double vision. Dysarthria, ask patient to speak and see if there is slurring. Ask patient if there is any to speak and see if there is any nasal twang or nasal regurgitation. And then dysphagia, which is last resort, dyspnea, which also because of the respiratory muscle paralysis. Next, this is how incomplete ptosis in the first picture. Next slide, please. To identify the impending respiratory failure, bedside PFT is what. How do you know if patient is having impending respiratory failure? A neuroparalytic patient having ptosis is okay with you, having nasal regurgitation is okay, but how do you know whether patient is having impending respiratory failure, which is a point of a time when you should intubate the patient and give him a artificial ventilation? So this is something very important, and I usually practice it, and I have been taught about it in my post-graduation. Single breath count is very important. Single breath count for normal person, in one single breath, I can count up to 30. But if patient cannot count up to 30, if he just have to take a second breath before that, or within a 10 or 15 counts, you know that patient is having an impending respiratory failure. One. Second is inability to speak a single sentence in one breath. Patient has to take multiple breaths just to complete one sentence. And third important is neck flexor weakness. Ask the patient to, a supine patient, to uplift his neck and ask him to touch to your palm. And if he can hold it, it's good. If it is not, then the muscle paralysis has come up to the neck, and which will be going to the respiratory muscles very fast. So these are the three things: single breath count, ptosis, elicitation of ptosis, and ask patient to say a sentence in a single breath, and neck flexor weakness. These are the few signs which you can actually see bedside just to see if patient is having impending respiratory failure. And I'm telling you, many don't know this, and they miss on diagnosing neuroparalytic snake bites, which is wrong. We should be able to do it, and we should be able to provide in time artificial ventilation, because this is happening in the rural area, and there are not everywhere artificial respiration is positive or present, artificial ventilation. So if you can diagnose this patient is going to need it, you can refer him in time. So next, vascular toxic snake bite do have a lot of local signs, which is local pain, swelling, bleeding, can cause bruising, local lymph node enlargement, blistering, local inflammation, infection, abscess formation, necrosis, and so many things. It can cause bullae and lot of things. So depending on the various species of the snakes, they do vary, but vascular toxic have got more local signs than the neurotoxics. Next, these are few pictures where you can see middle finger is gangrenous, there is necrosis, there is swelling, there is bleeding, which is usually seen in vascular toxic snake bites. Next, this is bullas and necrosis of the local part. Next, bleeding and clotting disorder of Viripede. So, Viperid. Bleeding from the recent wound and including the flank marks, it is seen in Viripede, the vascular toxic snake bite, and not in neurotoxic. This is two important things. So we should be differentiating between two every time. So spontaneous systemic bleeding first seen in the gums. So you must inspect the gums very thoroughly with the battery and asking the patient to open the eyes. You'll see little bit of bleeding, which is the first sign in vascular toxic snake bite. Conjunctival chemosis, later presentation. So basically, wherever there is capillary rupture or the mucosal bleeding will be seen, which is the first thing which happens before a major bleed happens, like hematomesis or hemoptysis or intracranial or intra-abdominal bleed. Next. Okay, this is what I told. You should thoroughly examine the gingival sulci with the torch. Abdominal tenderness, you should look at to see if there is intra-abdominal bleeding. Loin pain, if you see if there is renal bleeding. And lateralizing or localizing neurological sign or symmetrical pupils convulsions can be because of the intracranial bleeding. Next, myotoxic snake bites. We just briefed through it. It is a part of a snake bite, but not very common. So they are myotoxins. So they basically cause muscle pain, muscle swelling, and if there is a lot of venom which has envenomation, then the patient will have myoglobinuria because of the muscle lysis. This myoglobin is actually cola color urine, and if this is because of the increased muscle lysis, there will be increased kalemia, can cause cardiac arrhythmias. Kidney injury, acute renal failure can be seen because of the myoglobinuria, and paralytic signs, but they're not very prominent. So basically, these are the few. Next, and laboratory test. Next, so this is a gold standard. The 20-minute clotting time, whole blood clotting time test. You don't need anything, just you need someone to take blood, and you don't need any instruments to diagnose if patient is having a systemic envenomation. So this is very gold standard, very important, and this is what helps us treating 99% of the snake bites. 20 minutes whole blood test. You just have to take a non-contaminated test tube. You put it in the test tube. You wait for 10 minutes or 20 minutes, they say, and within 20 minutes it should clot. It should not come out if you tilt it. If still comes out if you tilt it, means it has not clotted, and it means there is decreased fibrinogen in this patient, and patient has got clotting disorder, clotting time abnormality, means systemic envenomation. Next, other things which are important is platelet counts. If patient goes into DIC, disseminated intravascular coagulation, there will be platelet will be low, thrombocytopenia, and patient will require fresh frozen plasma. If this is an indication that patient may be in DIC. I have seen a lot of them. Cell counts, there may be temporary early neutrophil leukocytosis. Then plasma, this is not very important. Next, biochemical abnormalities because of the breakage of the blood. RBCs, there will be high bilirubin, high LDH. DIC can cause acute renal failure and acute tubular necrosis, which is very bad. I had to dialyze a lot of patients, or maybe it must say 10 to 15 patients after vascular toxic snake bite. So renal dysfunction and acute renal failure can cause a lot of problems. Patient may become anuric. There will be acute tubular necrosis, and patient will require dialysis sometimes. So diagnosing or doing creatinine of all the vascular toxic snake bites is very important, because we may end up in trouble. Urine examination, yes, it is important. RBCs are present, which can be early sign of vascular abnormalities. Patient may have myoglobin in the urine, which is seen in C snake bite, that is myotoxic snake bites. Massive proteinuria is an early sign of acute tubular necrosis, and if proteinuria is present, you should be vigilant that patient may go into acute renal failure. So urine routine is important. Next, antivenom treatment. So we will talk about it because we all are doctor. We will talk about it. Antivenom, it is a polyvalent antivenom. So it has got anti-venom properties against mainly 4 species: cobra, crate, and viper, Russell viper and Sawskin viper. Next, we don't have monovalent. It is made in Hopkins Institute for us. So Indian cobra, Indian crate, Russell viper and Sawskin viper. Not included is sea snakes and king cobra. They are very rare. Next. What are the indication for antivenom? This is important. One is vascular toxic and second is neurotoxic. So if patient is having any systemic symptoms, it is an indication. If patient is having any laboratory abnormalities like coagulopathy, it is must to give antivenom. If patient is having without any local inflammation, without any systemic manifestation, if patient is having local inflammation which is involving the bitten limb more than half of its size, because if there is bite at the toe and swelling is above the knee, it is an indication for anti snake venom. If patient is having dry bite, it is not necessary. If patient is having dry bite, it is not necessary. If patient is having mild bites, it is not necessary. Neurotoxic signs if present like ptosis, external optic closure, any paralysis, it is must. And the requirement of ASV for neuroparalytics are way more than vascular. Next slide. So few more indications is local swelling involving more than half, rapid extension of the swelling, swelling after bites on digits and especially fingers. It is if it is rapidly spreading to the same limb, then there is requirement is necessary to give a anti-snake venom. And development of enlarged lymph node locally is an indication. Next. Contraindication. So before talking about the contraindication, I just want to tell you the how do I approach a patient of vascular toxic snake bite. So basically there are 4 categories. One is dry bites, which I told you there is no systemic problems or local problems are also very small. Then there is mild cases. Mild cases are local inflammation, no systemic manifestation, but local inflammation is less than half of the limb. Then there is moderate, lab abnormalities are there, and the local inflammation may be more than half. And severe, you will see there are problems with the internal bleeding or hemoptysis, hematemesis, or patient may have hypotension. So when we talk about contraindication to antivenom, there is no absolute contraindication except there is allergy. If there is allergy to any equine or sheep-based vaccine in the past, which is very rare, then it is a contraindication. But then if patient is having problems, if patient is having serious manifestation, then we must go with ASV because it is life-saving. As I told you, it is the only Sanjeevani we have. And what is the and this is last thing is very important. Test dose is not recommended. I see a lot of patients still, I see a lot of doctors still giving test dose and see if there is any reaction. Even irrespective of the fact if patient is having a problem, test dose is not recommended. If patient is having any anaphylaxis, you treat the anaphylaxis, restart the ASV again with a slower rate or more diluted fraction. But there is no nothing called as test dose that is required. If patient is having any reaction, you have to give it, because if it is indicated, it is must. So how do you administer? It is intravenous administration. Local administration is absolutely not necessary. It is not proven to be effective. Okay. Reconstituted freeze dried. So basically, how do you reconstitute it? You take a vial, a single vial is to be reconstituted 10 ml of NS. And if you have to give it in a drip, sometimes you might need to give it IV push. So how much is required? We will be talking about what is the dose. But how do you do it? You put it in the drip. What is the indication of IV push is usually a very severe patients, like patient have hypotension, patient have respiratory trouble, patient will require artificial ventilation. That is the indication of IV push. It has to be given in hospital because patient may go into anaphylaxis and sudden cardiac arrest. You have to have adrenaline ready in second hand if patient goes into anaphylaxis after ASV push. So usually it is to be avoided unless it is absolute necessary, and has to be given in intravenous infusion. How do you do it? If say patient require the as per, we will be talking about the dose. If say the patient requires 6 vials, so you just have to put a 6 vials, reconstitute them in 10 reconstitute so that is how, what is mode of administration, intravenous infusion in various patients. What I told you, adrenaline should always be ready before antivenom administration, so that's given in the good resource full setup. Local administration of antivenom at the site of bite is absolutely not indicated because it got shown not, has not shown any promise in treatment.
There may be some internet issue. Please, yes.
Am I audible?
Yes, sir. Yes, sir, you are now
Can you
audible.
go to the next slide, please?
Uh-huh.
But he is not visible.
Okay, so what is the dose of ASV? Let's just first complete the whole PPT, and I think we will have less questions. So what is the dose of ASV? So this very slide says that 10 vials of ASV is the stat dose of infusion which we have to give. So as I told you previously also, neuroparalytic snake bites will require lot of ASVs and vascular toxicity will require less. The dose of ASV for neuroparalytic is 10 vials stat. If you know what it is indicated for a neuroparalytic, if patient is having any symptoms of neuroparalytic, 10 vials is the starting dose. 10 vials reconstituted in 10 ml each, and then put it in a 500 ml of D10, D5 or NS and give it infusion. If patient is having impending or respiratory trouble, you just push it with the adrenaline in hand. You give those 10 vials over 1 hour. You reassess the patient after 1 hour. You see there is improvement, which is usually the case, that you can continue the 10 vials in next 5 to 6 hours. If there is no improvement, again give 10 vials for next 10. Usually required dose for the neuroparalytic is 25 to 30, depending on the symptoms. But this is what I'm telling you practically. This may vary, but 10 vials in first 1 hour. If there is improvement, 6 to 10 vials in next 5 to 6 hours. If there is no improvement, again repeat the status of 10 vials in next 1 hour, that is second hour, and just reassess. But that is the only thing we have apart from the artificial ventilation. And when we talk about vascular toxic snake bite, we know what are the indications. Indications is lab abnormality. Indication is bleeding from any side. Indication is more than half of the limb, local limb is involved, and fulminant or this the rapid inflammation, abnormal BTCT. So these are basically the indication for vascular toxic snake bite. And what you start with again the 10 vial of ASV. So basically this very slide is saying it is 10 vial of ASV. So what I do and what I start do is, and what is expected to be done is categorize those vascular toxic snake bite into 4. One is dry, no need of ASV. Second is mild, that is limb is involved, then the dose of the ASV is around 2 to 3 vials. And if more than half of it is involved, the inflammation is there for the more than half of the limb, or if there is lab abnormalities, or if there is bleeding from any side, the usual required dose is 10 vials. And you have to again monitor the symptoms, monitor the PTCT, and again give the further dose. If patient is having a cardiac problem, like patient is having hypotension or internal bleeding, then the dose will be again 10 vials. So 2 to 3 for moderate. For patient with lab abnormalities, you go for 6 vials. And if patient is having any cardiac problem like hypotension or renal failure, you start with 10 vials for vascular toxic. So this is the dose. There is no thumb rule for this is the dose. You have to give it as per the case, because all the cases are different. So you just cannot start everybody with vascular toxic snakebite with 10 vials. You have to basically grade them in mild, moderate, severe, and very severe, and then start the ASV. There is no contraindication in children or ASV or pregnant patients. So when do you repeat the dose of ASV? As we talked about in neuroparalytic, first 10 vials in 1 hour, you reassess. Patient is okay, you give 6 vials in next 5 to 6 hours. If patient is not okay, again give the 10 vials in the first second hour, reassess. Usually patient do respond within 20 to 30 vials. So maximum dose is 20 vials for ASV for neurotoxical envenomation. But on practical ground, you have to see if the patient is recovering from the symptoms. Then in the vascular toxic envenomation, repeat clotting test every 6 hours. So what you have done is you have given, depending on the category, 10 vials, say if you have given the first hour, and then you have to again repeat the dose. So how do you see if you have to repeat the dose? You have to repeat BTCT. So repeat BTCT has to be done after 6 hours of administration. So in first 6 hours you give 10 vials or 6 vials or 2 vials. After 6 vials you reassess. If the BTCT is again abnormal, you give the same dose again. If BTCT is normal, there is no need to give further ASV. It is not necessary to give ASV on the daily basis till the time patient is there indoor. So if the purpose is solved, if the BTCT is normal, if the bleeding has stopped, you no need to give ASV further. Next. So we talk about observation in the response of antivenom. Next. So patient may have nausea vomiting. Well, that is okay. Bleeding from the gum, which is the first sign of bleeding, which usually stops within half an hour. So that is one thing which you should see. In shock patient, which is seen in vascular toxic snakebite, you start with 10 vials, and within 1 hour you see that blood pressure is improving. If patient is requiring inotropes, then you say that there is decreased requirement or maybe no requirement within 1 hour. If bradycardia is there, there is settlement of bradycardia. The rate becomes normal. In neurotoxic envenomation, post-synaptic type, which is Cobra, may begin to improve as early as 30 minutes after envenomation, because ASV, anti-snake venom, will kill the various venoms, and post-synaptic acetylcholine esterase inhibitors or the receptors will not be blocked, and there will be improvement. In post-synaptic types, pre-synaptic will take time. They may respond up little late. Blood coagulopathy is usually restored within few hours. Bleeding from new and partly healed wounds usually bleeding from the new and partly healed wound usually stops sooner than this. So bleeding will stop early, and then VTCT will be normal. Active hemolysis or rhabdomyolysis will cease. Next, treatment of the bitten parts. So when we talk about ASV, we're talking about tackling the systemic envenomation. And what is the other part of the snakebite treatment is the treatment of the bitten part. So there, as we told, that if there is any necrosis, you have to remove the necrosis. If there is any bullae, you have to rupture the bullae, make sure that all the dead skin is gone. You give a limb elevation, which is above your heart. So if there should not be any edema, if there is edema, it will come gradually down with the gravity. You will have to give glycerin maxil dressing to the bitten part to decrease the swelling. antibiotic to prevent secondary infection, secondary infections, and you just have to give ASV, so body will recover on its own. So you should at least wait for 5 to 7 days, because depending on that species of the snake, it takes time for the healing of the local. Sometimes necrosis may take more than 1 week also. Sometimes it will be healed within few days. So depends on the types of the snake and amount of venom, it changes. So in brief, we'll talk about the complication. If there is neuroparalytic envenomation, what is life-saving is ventilator. Just go next slide. Just a second.
Sir, we will take more question answers.
Yeah. I'll just brief through this, because I think you should know about it. If you're not going to do it, you should know. First is what in neuroparalytic snakebite, what you should give patient. You should have a artificial ventilation, that is ventilator available. If it is not available, you make sure that you diagnose impending respiratory failure early. And there is a little role of neostigmine in post-synaptic cases, like in myasthenia gravis. Neostigmine do increase your power, so you give neostigmine. There is something called as atropine neostigmine schedule. Next slide, please. So this is atropine neostigmine schedule. If you do not have ASV, you may have neostigmine. You give neostigmine. Prior to that, you give atropine subcut, and you give 1.5 mg of neostigmine, and you see there is objective improvement in the patient. Then you may have to repeat this atropine neostigmine dosage every 30 minutes before you reach to the center where ASV is available or ventilator is available. So patient will show improvement if patient is having neuroparalytic post-synaptic type of toxicity. If patient is not responding in first 3 cycle of neostigmine, don't give it. If he is improving, then you can give it every 30 minutes until you reach the center. Next, post alkaline diuresis is important. So this is basically sequence of post alkaline diuresis. You give him furosemide, then you give him NS diluted in with soda bicarb, and if you do it in first 24 hours, you can prevent acute tubular necrosis. It has to be given with a patient who has got proteinuria, because they are more going to land up in trouble. And I have seen patients who require dialysis for 3 months, 4 months, and unless their kidney recovers. So it is not a good thing. If you can prevent it with forced alkaline diuresis, you have to do it early. Just do urine routine. If there is protein, do it early. Or irrespective of that, if you do it, then also it is good for vascular toxic. Next. So this is if you're doing forced alkaline diuresis, there should be diuresis, and each cycle is 2.5 hours. You have to see how much is the urine output. If the urine output is good, you means that patient is responding to the forced alkaline diuresis. You can give up to 3 cycles. It can help prevent acute tubular necrosis. If there is no response, stop it. If the patient do not have adequate urine output. So what are the indication of dialysis? With creatinine more than 5 is an absolute indication. Patient is having acidosis. Usually patient will present with high creatinine and oliguria or anuria. They will require. If they are having high creatinine, they will usually have high potassium. So hyperkalemia more than 7, fluid overload, pulmonary edema these are the various indications for dialysis post vascular toxic snakebite. Not in neurotoxic, you don't see that. Then again, shock. Patient will develop shock, will require inotropes, will require a lot of fluids. You have to titre. Patient is going into pulmonary edema. Then depending on that, you have to give fluids. Inotropes, noradrenaline is the inotrope of choice. So you have to make sure that patient is having normal blood pressure initially. If patient is having normal blood pressure, and the patient is having hypotension also, ASV will make sure that blood pressure becomes normal. But patient should not have hypotension for long, but this again can cause prerenal acute renal failure. So you have to keep it normal. Next. So that was all from my side. I tried to cover everything. So thank you very much for the opportunity. We can go with the question and answer, if I can answer.
Thank you very much, sir, for an excellent presentation. You have enlightened us about the facts, the myths, and the emergency management of snake bites. I'm sure all our delegates, especially those practicing in rural areas, will be highly benefited by the knowledge that you have shared with us. Now, sir, we have some questions in the chat box. Can we start with the question
Okay.
and answers? Okay.
Yeah, sure. Anytime.
So there's a question that in case a patient doesn't know what has bitten him, how can we confirm that it is a snake bite?
So basically, two types of bites are important clinically. One is snake bite, second is scorpion sting. When patient doesn't know what has bitten him, this is what is being called as unknown bite. So there are few symptoms that you should know for the scorpion sting. Scorpion bite is called a scorpion sting. So we will first talk about scorpion sting. It is very important when we're talking about snake bite, we should talk about scorpion sting. This is a very good question because I have seen I have been working in the government setup also. I have seen a lot of young people coming and they don't know how to differentiate whether it is snake bite or scorpion sting. So there is algorithm for scorpion sting also. If it is scorpion sting, then patient will have excruciating pain, local pain. Patient will have sweating, local sweating and whole body sweating. Patient would be drenched. Patient will have hypertension or hypotension. Patient may have tachycardia or bradycardia. Such a high intensity is not seen in snake bite. Then patient will have penile erection. Patient will have local tingling sensation. Patient will have perioral tingling sensation. Patient will have tingling sensation in the same extremity or whole over the body. Patient may have difficulty in breathing. Patient may go into pulmonary edema. So these are the few signs of scorpion sting. If you clinically can judge if it is a scorpion, then you know that it is not a snake bite. Even if you know it is scorpion bite, you have to go with BTCT because BTCT is something which can tell you that it is vascular toxic. If BTCT abnormal, irrespective of the fact what your clinical judgment says, it is a vascular toxic. So that is the case. The what remains is neuroparalytic. So you have to elicit and see again patient if patient is having any neuroparalytic symptoms like ptosis, dysarthria, nasal crying, nasal regurgitation. We talked about it. So if patient is having symptoms, you can go for vascular scorpion sting or neuroparalytic. And patient is having any bleeding or abnormal BTCT, you go for vascular toxic. All other bites are absolutely harmless. They just can cause local problems, so they don't cause systemic envenomation. So scorpion sting and neuroparalytic has to be judged clinically. Vascular can be judged on the basis of lab abnormalities. That is one thing. Having said so, I have myself come across a dilemma a lot of time. Then what you have to do is you must keep the patient indoor for 24 hours to see if there is any deterioration. You may not be able to diagnose it at first, but then usually the symptoms will gradually come and you can then diagnose. So this is basically a clinical judgment. So you must know about the scorpion sting also. One more thing I had to tell you is the site. What happens is where if it is near the paddy fields, if it is in the jungle, then usually it is snake. Usually, where there is no hard and fast rule. If it is in the around the home or maybe then it is usually scorpions. Scorpions are more prone to cause bites in the summer season when they come out. In these snake bites can come perennial, they can come 12 months, but usually in the rainy season. So this is how you can judge little bit, but then clinical judgment, that is the treatment.
Very nicely explained, sir. Second question. What is the dose of ASV, sir? You have already answered this.
Yes.
At what platelet count anti-snake venom is indicated?
The platelet count it's not at all an indication. Less platelet count is an indication of DIC. If there is less platelet count, you may need to do something called as DIC panel. DIC panel is you see how much is the fibrinogen, APTT, PTINR level, and you see that all these things are abnormal. Then you label that patient has gone into post snake bite DIC. Post snake bite DIC, what you require is cryoprecipitate or fresh frozen plasma, because patient do not have those in their blood. They have been, the patient goes into consumptive coagulopathy. So low platelet can be a indication that patient may be in DIC, and then patient will require FFP or cryo. It is not at all telling you if a patient is requiring ASV. ASV has to be given for vascular alag and neuroparalytic. For neuroparalytic, we talked about it. Mild and dry, you don't give. Moderate, severe, very severe, you give. Platelet, if they're low, definitely patient will require. Patient is going into DIC, patient will have abnormal BTCT. In the first, platelet will drop later.
Okay. Is there any kind of vaccination against snake venom? I think doctor wants to ask before a snake bite.
There is no vaccine.
Is there any role of steroids in the treatment of snake bite?
No. If patient is having anaphylaxis to ASV, patient may require hydrocot. That's a stat dose. There is no other. Don't give steroids. It will decrease the immunity. It is only if there is anaphylaxis. That too, adrenaline is the magic drug. We give every hydrocot, but then adrenaline is the magic drug.
Is ASV available with any general doctors apart from rural government hospital?
ASV is available in all the government hospital. I run a private hospital. I do have a ASV. So ASV is also available in private setup also. The Hopkins Institute do provide it, and we do get it in, if it is hospital is registered. But usually you see a lot of private practitioners do not practice it because it is an acute emergency and patient may require ventilation and needs a lot of vigilance. But all the government setup ASV is available, and in private setup also ASV is do available if the setup is good.
Yeah, because sir, there is one question on YouTube which is related to the same thing, that do the general practitioners or the OPD base, can we treat the snake bite? You will suggest no.
I would say no, because what happens, we must first go for the diagnosis and reassurance and first aid. It has to be treated. The ASV has to be given in a good setup, because I have seen people fainting in front of my eye because of the anaphylaxis, and anaphylaxis is absolutely rampant. We say, I have told you that 10 vials is to be given in 500 ml first 10 for 1 hour. You may push the ASV, but ASV is very notorious causing anaphylaxis. And if you are good enough that you can manage anaphylaxis, which may require ventilation, which will require adrenaline, and which will require a monitor, oxygen setup. So I would not say that it should be treated by a general practitioner. It is better to be treated in government or good private. If even if it is a small bite, it can go bad. So not recommended.
So much, sir. And when transporting the patient, suppose this happens in the far, like village area, and the people over there, they are carrying the patient to the hospital. So in meanwhile, reassurance and splinting, what else they can do, as a first aid?
Splinting, then crepe bandage, immobilization of the limb, which is important. Patient should not walk. Patient should come on a stretcher. It is important. More you give rest, more is the chances that patient will have increased envenomation. And as we told about a lot of things, what should not be done, that we should more focus on rather than what we should be done, because this is nothing else. This is immobilization, splinting, bandage, and immobilization means do not make patient to walk. So these are the only 4 things that you can do. But what is not to be done has got a lot of list.
Yeah. So there is a question in the chat about tourniquet tourniquet. So should we?
Tourniquet is absolutely not indicated. It is definitely not indicated. Very tight tourniquet can cause arterial obstruction and decrease may cause vascular ischemia, and if it causes vascular ischemia, it can cause necrosis. So it has got no role in decreasing the envenomation. We give splint and bandage just to immobilize and stop the lymphatic drainage, but venous and arterial flow should not be touched to, and that's why tourniquet is absolutely not indicated, not necessary.
Yes,
immobilization is very important.
Yeah, Gayatri, just one question I will take and then over to you. There is a question from north side of India, and they talk about the spitting cobra. Like they say that the venom, they spit it, the snakes, and then what happens is itching or damage to the skin, or the person goes blind. So can you just tell us about?
This is myth. There is nothing like that. We have got four vials, four main categories: vascular, neurotoxic. They bite with their flank. They have got. I studied in KM hospital, so I had a privilege to go to Hopkins Institute. So I know the myths that people can ask. So initially, when Dr. Pushkar Vaishampayan told me to give this talk, I was very happy. So nobody splits. It is the bite with a flank. They have a flank and there is a flank mark. And when it bites, it goes into the capillaries and lymphatics, and from where it spreads. So that is the mode of transport of venom. Nobody, if something comes on your body, it can be something which can cause itching, but they do not cause any systemic envenomation. It can be anything, but they do not split. This cobra or anybody else do not split. It's a wrong concept. It's a myth. They can just bite, and that is the way they do envenomation.
Okay, thank you so much. Dr. Gayatri, please take 2-3 questions and then I will come back. Thanks.
If a patient had snake bite once and ASV is given, and then the patient gets discharged, and again if the patient gets snake bite within 15 days, so in that case, can we again repeat ASV?
Definitely. Definitely we can repeat the ASV. Just a second. Definitely we can repeat the ASV. There is no contraindication for ASV. If patient is indicated to be given ASV, we can give it in 15 days, 10 days times. No problem.
Okay. What is pre and post synaptic toxin?
Okay, this is theory again, and I say that I forgot. So post synaptic basically is I know about myasthenia gravis, so I can talk about it. Post synaptic is basically there are two synapses. This is a presynaptic neuron and post synaptic neurons. So they act at a neurosynaptic junction. So in the post synaptic neuron, there is something called as acetylcholinesterase receptors. And in snake bite, this snake venom has got the enzymes which will bind to this acetylcholinesterase enzymes, and they will not allow normal conduction of the current through the nerves, because they are blocking those acetylcholinesterase enzymes. And because of this, the nerve conduction won't happen, and that's ultimately muscle is not going to work. So that is how the mechanism of post synaptic transmission, that is the mechanism of how cobra venom will cause problems. This is the same mechanism for myasthenia gravis, in which the autoimmunity do works. That's why I know the post synaptic. The presynaptic, I'm really not sure. It's got nothing to do with the treatment, and it does not have any problem with me for the treating the patient.
Right. Someone has asked how much time one has post venomous snake bite.
Sorry, how much?
How much time one has post venomous snake bite? I think
we talked about it. Within half an hour for the neuroparalytic snakes, the patient can have problems. For the cobra, crate can go up to 24 hours to 36 hours. So first 24 hours you may not have any symptoms in some cases, and after 36 hours usually there should not be any problem. And in vascular toxics, usually what we practice is 24 hours of observation. If patient does not have any symptoms for 24 hours, I think you don't have any problem.
Okay. And what is the dose of ASV in pediatric group?
Pediatric group ASV dose is the same. Again, dry, mild, no problem. Moderate, severe, very severe, you have to give. If it is more than half of the limb and abnormalities of the lab are there, then you give 2 to 3 vials first 6 hours vascular toxic. If it is severe, that is patient is having systemic problems and hemoptysis and all, you will give 6 to 10 vials. So there is nothing is 6 or 10, you can give anything in between. If it is very severe cardiac problem, hypotension, you give 10 vials first 6, irrespective of the fact the patient is having it's a pediatric or this.
Okay, sir. And what is the maximum dose of ASV you have given to a single patient?
35. There is this is one I just wanted, I had to tell you, there is one species called as locally they call it as a Cambria. I have tried to search it online, but I have not found. They usually see in the Raigad and Dapoli and Mandangarh area. This is a vascular toxic snake bite, and it gives very bad local inflammation. Does give lot of severe systemic inflammation also. They themselves tell you that it is a Cambria which has bitten them, and if it is the case, then I have seen few patients, and I had to treat them for 15 days, maximum up to 35. That's what I remember.
Dr. Snehal?
Yeah, so my question might sound like foolish, but I want to ask that does ASV have expiry date?
ASV does. It does have.
Okay.
I
because
just read a question. I'll just finish that also. ASV, what is the cost? The cost of ASV is 500 rupees per vial in private, because I have it, I know. And in government setup is absolutely free. They do have, but very long expiries. They have expiries of 4 years, 5 years expiries.
Why I ask, because there are rough statistics that so many deaths in India because of the snake bite. So can the drive be done in the such areas, even in the private hospital where at least ventilator is there or something like that? So can we ask them to just have the like ASVs handy to them? I don't know, but if it works,
Look, every doctor has got its way to practice. These are acute emergencies. So acute emergencies need good ICU setup. They will need vigilant monitoring. Not everybody is keen to do it. And one more thing is, patient was normal before the bite, and if after bite everything changes, this patient can go bad and die. So in private setup nowadays, what is the condition. So people are not much happy doing bites. They do it in the bigger setups, but not everybody is very keen. But it has got. We can absolutely do it, but then I don't think.
But thanks.
Discuss with the other colleagues, senior colleagues. They are not.
No, why I asked, because as Dr. Jyoti told you that, like we have this first aid ka course with Pratham Education Foundation, and they ask such question that, government hospital is so far from our area, what we can do and something like that. So if the private hospital is in the middle and if they have such provisions, I think it would really help.
I think we're talking about very rural area. I don't think in very rural area you would have a private hospital which can tackle snake bites, bad snake bites. And I would say only snake bites, because it can turn bad anytime. But government, I am working in Dapoli, which I say it's very remote. But I have seen even the sisters here are very well versed in the snake bite. The rate of success is very high. Very few patient needs referral, because everybody's they are experienced in it. Government is the best setup for all the snake bites. Very bad snake bites, or those who require ICU can be treated in private. But in PHC also you have got in the primary healthcare center also you have snake bites. But the problem is that they don't treat because they don't have good facilities. Every taluka has got a rural hospital or a sub-district hospital. So I think it can be around 30 kilometers or 20 kilometers. Everybody in India should have a government referral center where ASV is available and can be treated. And you always have that much of time. So better to go in a good resourceful setup than to treat. What we should be more talking about is the first aid, then the myths. What happens is people still go and do jhadu pala. They put a lot of herbal medicines, and they still think that we should be doing drives against that with the local doctors, which people do believe, because someone coming from outside telling them don't do it, they don't do it. But the local, you can do drives to clarify these myths, so that patient should not come late. Patient do come late, and then we miss them.
Yeah, sure.
So that is the drive.
Sir, one more silly question. Does snake bite once, or does it bite again and again?
It bites once, or it can bite again and again. So that is both the answers are right. So what is the snake bite? Snake bite snake do not come and bite you. It is his reaction. He just want to save himself. So if you go and put your leg besides him or on him, then he is going to bite you. He's get multiple chances. He will bite you multiple.
Okay,
He will try
this
to
question
run. He
was
bite you
asked.
once. So they are not attacking you. They are just trying to protect themselves. So that is what you should see. I have seen a lot of people with a lot of flank marks. So usually patient 99% of time there are only 2 flank marks. But sometimes patient may have multiple flank marks and they say that I was bitten a lot of time. But it happens. It is very rare. It can happen. No?
Okay, okay. Thank you, sir. Thank you.
So Dr. Jyoti, this is 505. So can we go ahead, or because the questions from our first aid team, they are there, I can send the questions to sir, whatever you say.
Sir, do you have time?
I don't mind.
Yeah.
We can go ahead.
2 to 3 questions more. Is it okay?
Okay, fine. So there is a myth in Indian villages about snake drinking milk. What you would say about it?
That is wrong. Snake eat insects. They don't eat milk. They don't drink milk. It is wrong.
Okay. Okay. One you answered. Yeah. Many times, there are people who catch the snake and put it in the bottle. So will it die, or like what happens to it? How it can be alive?
And what I know, this is not related to medical field, but what I
No,
know.
it's like the questions from the villages. They want to,
Okay,
have.
they don't die. Okay. If they don't get oxygen, they'll die. If you put them for the longer time, they'll die. But what people do, they like what we told about the Sarpomitra. If they have anybody has any problem, they'll come, they'll catch the snake. It usually they leave it in the jungle. So
Right.
they don't die. If they don't get oxygen, they'll die. If you put them in the locked container for a long time.
Sure. There is a question from, I think, the person who got bitten by the snake. So he's asking that, 15 to 20 days, even after taking the treatment, he had some itching and some swelling at the location. So,
very nice question.
So
very nice question. It's good you are asking this question. So this is called as serum sickness. This is a anaphylaxis reaction to ASV, which can happen up to 2 weeks or 3 weeks. So patient will have this problem like itching. They can have swelling on the eyelids and all. This is a serum sickness which can happen with any drug. So immediate is anaphylaxis and delayed is serum sickness. So if you go to the microbiology book and you see there is hypersensitivity, there is something called as serum sickness. Serum sickness is well known with the ASV. So patient can have serum sickness to ASV. You have to tell them, and the treatment will remain steroids. You have to give them 1 mg per kg of prednisolone and local antihistaminics and symptomatic treatment. Serum sickness will require steroids.
Steroids. Okay. Yeah. We need to convey this, I think. If Dr. Anjana is listening, please convey this. Yeah. So there is connected question, any side effects of ASV and how to manage anaphylaxis?
Anaphylaxis management everybody must know. It is despite the fact whether we're talking about ASV. So anaphylaxis 0.5 ml of adrenaline IM or you know what 1:10,000 diluted, and then you give 0.5 ml 0.1 ml IV. If patient has bad anaphylaxis, he falls in front of you, he has got hypotension, just don't think, give him 1 shot IV, 1 ml IV or 0.5 ml IV. I recently we have completed a big drive of COVID vaccine. So there also it is very clearly written in the government protocol. If you think patient has got anaphylaxis, give 0.5 ml of adrenaline. You may be wrong, it is not going to be harmful. You may be wrong, but it can be life-saving. So adrenaline 0.5 ml IM or 0.5 ml IV. Just do it. It is not a problem.
Thank you so much. And the last one, you told about the indications of whatever, the venomous snake bite and the indication to start the antivenom. Okay. So if this start, like patient is delayed already to come to the hospital and the symptoms have started. So we should not wait for the lab test, right? Or should we that PTCT and everything and then we start?
Patient is having a definite snake bite. and patient is bleeding, you start ASO. You don't have to wait for the BTCT. Patient is bleeding in front of you and patient is having snake bite, you do it.
Okay.
If patient do not have any symptoms, then you see if it is systemic envenomation and can be prove it with BTCT. But if patient is having symptoms, go for it. Give ASO.
Okay, sir. Thank you so much. And this was the last question. So I will just ask Dr. Jyoti, what is the next step? Please guide. Thank you so much, sir. It was wonderful talk and question answer.
Now I request Dr. Prakash Mahajan sir to please conclude the lecture, and then Dr. Anjana will give the vote of thanks. Yes, Dr. Prakash sir. Sir, yes. प्रतीक प्रकाश सरांना अनम्यूट नाही केलंय का होस्ट?
मैम प्रकाश सर लीव हो चुके हैं.
ओके ओके ठीक है. यस डॉक्टर अंजना.
Yes. Hello. Am I audible?
Yes.
Okay. Thank you, Dr. Snehal. Thank you, Dr. Jyoti ma'am. Dr. Anjana Rathore here. As a volunteer of MCF, I am working for First Aid Project. I want to share 2 lines. सरस्वती के भंडार की बड़ी अपूर्व बात, ज्यो ज्यो खर्चे त्यो त्यो बड़े, बिन खर्चे घटी जात. And during this project, I realized कि जब हम ज्ञान बांटते हैं तो ये और बढ़ता है. And really, after this project, I realized कि we need to upgrade ourselves regularly. This project is really a very good learning platform for not only students but for doctors also. We learned many things, we upgraded ourselves and faced a lot of questions on snake bite. So my special thanks to Dr. Suyog Bhagwat sir. Thank you so much, sir. You cleared our all doubts and question answer session was very good. Many thanks for this beautiful evening. Session was totally full of knowledge. Definitely this will help us. Thank you, sir. And I would like to thanks to Dr. Pushkaraj and Dr. Gayatri for your kind support. And thank you to all doctors who joined this session through Zoom and the YouTube link. And thank you all of you for your precious time. And last but most important, thank you so much to White Coat team for your technical support. And my request to all doctors, please join ongoing and upcoming courses which is organized by MCF to upgrade yourself. Thank you so much, everyone. Yes. Hello.
Thank you, sir. Bhagwat sir, thank you very much.
Thank you. It was my pleasure. Thank you.
Yes, sir.
Thank you, sir.
Yeah.
Can we leave?
Yeah, sir. Yes. Should we end the meeting? Yes, Pratik?
Okay, ma'am.
Yeah.
Thank you.